Hello everybody. Over the next 20 minutes we will have a short discussion on the requirements and the challenges of using MRI for prostate cancer screening. Here are my disclosures. Now, we know that case finding strategies at a single time point don't really work, and there's been recent data showing that 50% of the deaths in a prospective trial occurred in men with a normal PSA. We've also now learned that PSA screening after shared decision making does not eliminate the harms of prostate cancer in terms of the over-diagnosis and over-treatment of indolent cancers. However, we can be very sure that if you perform programmatic screening with PSA and reflex systematic biopsy, that we can reduce mortality greater than 20%, and we've got good evidence from Scandinavia showing this. So what we can say now is that PSA screening is only acceptable if it's one, programmatic, and two, if we can reduce the harm while maintaining the detection rates of cancers. And the way we reduce harm of prostate cancer is by stopping blind biopsies, using MRI so that we can avoid biopsies, performing safer and more accurate MRI-directed biopsies. We need to improve the uptake of active surveillance, particularly for grade group 1 men and those men with microscopic grade group 2 disease, and there may be a role for other gland sparing treatments such as focal therapy. Now, MRI can deliver 4 benefits that we've documented in secondary screening or secondary care, and that is it reduces the number of men undergoing a biopsy, it reduces the diagnosis of indolent cancers, and this of course relate to the rule out ability of MRI. We also know that it helps perform more accurate targeting biopsies, and it is not inferior for the detection of clinically significant disease in biopsy naive men. So the evidence in secondary care when the prevalence rates are higher is in fact now well established. The issue that we need to ask is, do these benefits then translate into the primary screening setting when we do screening by MRI alone, or if we do MRI after PSA? And that's the thing I want to discuss next. So if we look at this screening study that was performed in the UK, it was a pilot study where 408 men from 7 general practice studies were invited for screening at 2 imaging centers and were imaged at both 1.5 and 3T. You'll notice that a positive PSA is defined by a PSA of greater than 3, and an MRI at that time was defined as a PIRADS 3 to 4 and 5. And these men all underwent a transperineal biopsy, an MRI-directed biopsy, and systematic biopsies as well. So what you'll notice by looking on the right-hand side is that 41% of men underwent a biopsy for a positive test. Now, this is an excessive number of biopsies, but it was important for us to know what the background prevalence of clinically significant disease was. And you'll notice that about 10% of men had a positive MRI. If you defined it as a PIRADS 4 and 5, 10% roughly had a positive PSA greater than 3 nanograms per ml. And if you look at the graph on the right-hand side, you'll see that the number of men undergoing a recommendation for a biopsy, you can see, is about 10%. These are the men with positive scans. You'll notice that the MRI strategy had fewer men with non-productive biopsies. You'll see that if you used PIRADS 4 and 5, you detected more clinically significant cancers compared to the PSA strategy. So this seems to indicate that MRI as a stand-alone test is in fact quite efficacious for the purpose of screening. What about if you perform MRI after a PSA? Let's have a look at this study that was recently published in the New England Journal of Medicine. You'll see that 1,532 men had a positive PSA, and remember in London that figure was 10%, so this is more or less the same, and these men were randomized either to a systematic biopsy or an MRI-targeted biopsy if they had a positive MRI, and the positive MRI was defined as PIRADS 3, 4, and 5. What you'll notice by looking at the graph on the right-hand side is that there were fewer biopsy procedures undertaken when an MRI was used compared to a systematic biopsy. There were fewer men with a benign or non-productive biopsy. There were fewer clinically insignificant cancers, and there was no deterioration of detection of clinically significant cancers in men with an MRI that was positive. So if we try to summarize this experience, what we're saying is that the benefits that we saw in secondary care do in fact translate into primary screening. And what we've noticed is that there are limitations. And one is there's a limited availability of high quality MRI because it requires specialist equipment, training, and software. But we haven't eliminated the false positive harm of over-diagnosis and unproductive biopsies. Those are still there when we move into the primary care setting also. Now, some of you will have already seen this diagram here on the right, which is the EAU pathway for prostate cancer screening. And you can see it relies on 5 key elements. 1, an age and a risk-adapted PSA. 2, a clinical assessment. 3, an MRI risk stratification. And 4, an optimized biopsy strategy. And 5, there's an inbuilt safety net in the scheme that the EAU is proposing. So if we look at this scheme carefully, what we notice is there are multiple issues that we need to tackle, and this means that we need to optimize the MRI and somehow integrate it into the screening pathway. So let's talk about the protocol. Clearly there are multiple protocols that we can use for prostate MRI, and in the screening setting I think all of us would agree that this needs to be a uniplanar biparametric MRI with T2 and diffusion imaging, and that is it. Something that looks a bit like this. So what you can see is just axial T2s, top left, and the diffusion rated sequences here, and then the corresponding ADC. Now, of course, you may want to think about substituting AI acquisitions instead of these images. So you may want to use DR boost both for the high B-value images as well as for the T2 to try to reduce the acquisition times down, particularly for the T2 sequences. But what is a positive and what is a negative MRI in the screening setting? Not in secondary care, but in primary screening. Well, clearly it appears that we should only be calling patients with PIRADS 4 and 5 lesions in the primary setting because the pretest probability is lower than in secondary care. So PIRADS 4 and 5 is much more suitable because of the lower prevalence, and these are the 2 prevalences that I showed you before in the other 2 trials. One trial had a prevalence of 12%, the other trial had a 4% prevalence. So it's going to have to be PIRADS 4 and 5, and we may have to use PSA density also. In fact, if you look at the studies, the exploratory studies that have been done using MRI, and I've just listed them over here, you'll see that the prostagram study identifies PIRADS 4 and 5 as being the cutoffs. The Reimagine study just uses 2 sequences, the T2 and the B2000 image, that's it. No ADC maps, nothing. Just those two images, which is interesting. The PROSCAR study used 3 to 5, and the MVP study used 4 and 5. So you can see that there is some variation of how MRI has been used in these exploratory initial studies of MRI for primary screening. But the other interesting thing to note is what is the prevalence of grade group 2 and above, or clinically significant cancers. You'll see 4%, 10%, 2%, 5%. So we can expect to see somewhere in the region of 4, 5, 6% background prevalence of clinically significant disease for population screening. The other interesting thing to note is how often is an MRI going to be positive, and you'll see 11%, 16%, 11%, 10%. So we're expecting 1 in 10 men to have an abnormal MRI if we used MRI for primary screening, not taking into account the PSA test. The other things we need to talk about in terms of the optimization is, what do we do with scans that are difficult to read or incomplete, these so-called PIRAD 0 scans? What do we do with indeterminate scans? What's going to be the effect of image quality? As we said, we need to talk about certification, but we also need to talk about AI. So here's an example of a man who is being screened because he has a family history, but his PSA is normal, less than 1, and you can see that the AI detects a lesion in the left peripheral zone amongst emerging cystic atrophy. And you'll see that the AI gives a lesion suspicion score of 85. So that's basically a PIRAD 5 lesion. You can see that here on the left-hand side. So this lesion deserves a biopsy. But what about this other lesion in the same patient? You can see that this, in fact, has a very low suspicion score, 67, which equates to a PIRAD 3 in this particular software. Now, is that going to be a good candidate for biopsy? Well, in secondary settings, we would certainly biopsy that. But in primary screening, are we going to biopsy that? That's the question that we need to sort out. In other words, what is the operating point at which we say we should biopsy and we should not biopsy either positive or negative MRI? Regarding the use of MRI in the screening pathway, one of the first things we need to do is decide whether we should be doing primarily MRI, or should we be doing an MRI after a biopsy, after a PSA is abnormal? Why is that important? It's important because it looks like about half the cancers that are eventually detected, if you just do MRI by itself without PSA pre-screening, occur in men with a normal PSA. And you can see this here. So in the prostagram study, of the 17 men with clinically significant cancer, you see 8 men occurred in men with a normal PSA, i.e. less than 3. In the reimagined study, it was 15 out of 29. Here you can see it was 3 out of 4. And here it's 2 out of 11, but there was poor biopsy compliance on the PSA arm of the screening study. So what we can say is that it looks like half the cancers would be missed if we used a PSA threshold of 3 and above and then used an MRI after that. So that's something that we need to be cognizant of. And then what combination of MRI and PSA should be used to undertake a biopsy? Now that's an interesting thing that was looked at by the prostagram study. And you can see that in the prostagram study, if you had performed only a systematic biopsy when the PSA was greater than 3, in other words, the screening method that's currently has level 1 evidence, you would get about a 10% biopsy rate, and I said it would be about 10%, and you would detect about 1% of cancers. Any MRI strategy improves the cancer detection rate. You can see how the graph moves upwards. Now, if you took a PSA greater than 1 and then you biopsied pyrides 3, 4, and 5, you'll see that the cancer detection rates does increase. It goes up from about, say, 3 to 4%. But the biopsy rate also increases from 10% to almost 25%. So that's not an acceptable strategy. On this end, which is what the EAU is suggesting, is that if the PSA is abnormal and an MRI is abnormal, then you do the biopsy. Then you can see you reduce the biopsy rate, which is worth having, but the cancer detection rate only goes up to 1.5%. It looks as though the most optimal strategy is this one, a PSA of greater than 1 and a pyrides 4 and 5. So this is one way of trying to understand what might be the best combination of PSA and MRI to undertake a biopsy. This again is a proposal, and it's something that we need to think about. The next challenge that we need to think about is, in a man coming to biopsy, should you be doing a targeted biopsy alone or a targeted plus systematic biopsy? In fact, this was looked at in 2022, where 1,200 men had a positive PSA and then underwent an MRI. Now, these patients were randomized. They were randomized to a systematic biopsy for everybody, plus an MRI targeted biopsy if the MRI saw something, versus only targeting the MRI depicted lesion. And you can see that randomization in the middle panel. When you look on the right-hand side, you'll see that the number of men coming to a biopsy was about 1/3 compared to the people who were having systematic biopsies. So all of these men had systematic biopsies, but about 1/3 of these men had a MRI targeted biopsy for a positive MRI. You'll see that there were fewer unproductive biopsies if you performed an MRI targeted biopsy alone. There were fewer diagnoses of indolent cancers, and you can see that there was no detriment in terms of the detection of clinically significant disease. The last thing we need to just briefly discuss is the cost effectiveness of using MRI in screening. Now, of course, multiple factors, as you see on the right-hand side, determine the cost effectiveness of using MRI, because screening requires a huge resource commitment and a large infrastructure. But we do have preliminary evidence to show that MRI is more likely to be cost effective than the normal screening pathway. So if you look at the left-hand graph, you can see this is the MRI screening strategy, and this is the normal screening strategy. And if you look at the probability of something being cost-effective at, say, 20,000 euros, you can see that MRI is much more likely to be cost-effective compared to the regular screening pathway. And if you look on the right-hand side, you see a similar result, where this is the PSA followed by the standard biopsy, and this is the MRI strategy over here. And you can see that MRI is much more likely to be cost effective compared to the regular screening pathway. So it looks like in these two studies that the MRI model will be cost effective if it's done after PSA. The last thing we need to talk about is certification of readers and center accreditation. Now remember that certification is about individuals and whether they are allowed to perform specific functions, whereas accreditation is for service providers, or if we can think about this as accreditation of units or accreditation of even MDTs. Now regarding accreditation, when we talk about accreditation, we must have a program that has defined objectives There must be a multidisciplinary team within that program. You must have well-defined protocols. There must be some kind of recognized external accreditation that they're doing things well. There must be a quality assurance plan, and of course patient education is highly, highly important. So here are my final points. Population screening for prostate cancer detection is a new indication for prostate MRI, which does seem to allow the detection of high-risk prostate cancers while reducing harms from biopsies. Number 2, we do need to think about optimizing MRI for screening. In other words, talk about protocols, accuracy, reliability, interpretation criteria, etc. Finally, we need to think about how we are going to optimize the use of MRI within a screening pathway. In other words, its integration into a multi-step diagnostic pathway in a way that is cost-effective. I hope you found some of these comments useful as you think about whether you are going to be engaging in using prostate MRI for prostate cancer screening. Thank you very much for listening.